Good morning, good afternoon, depending on where you're joining us today. Thank you for joining us to hear a little bit around breast masses and whole body imaging as it comes to MRI. I'm Eric from Prenuvo. I've got a couple other great people joining today to go into the information. We have Dr. Vikash Modi, who's our Senior Medical Director of Preventive Medicine. And we also have Dr. Ben Johnson, a Prenuvo radiologist here as well. And then myself, Eric Chafe, VP of Sales. So real quick, before we jump into the topic, I'll start at just a high level around Prenuvo. I'm sure if you're here, you've heard of us on some level. Maybe you're working with us already, referring patients, and maybe you're just doing a little discovery and investigating what we're all about. We are a dedicated whole body MRI imaging practice. Today we have 17 clinics. And we'll probably be close to doubling that by the end of next year, right? We're the world's first imaging practice focused on this. Until today, our focus really remains on longitudinal, routine whole body imaging. At this point in this space, that makes us the largest, certainly in the US, doing this, with an estimated 10 to 15 times more scans completed compared to any type of similar practice doing this or even comparable academic centers of excellence. We're proud to say this is quite literally our expertise. We have over 100 members on our clinical team between radiologists, PCPs, nurse practitioners, and we're continuing to grow on this front. Quite proud to say that our team has played a major role in the technological advancement of MRI application for general whole body imaging. And we expect to remain at the forefront of this movement. In the beginning, we started quite small, scanning really a handful of people a week. Our founding radiologist would literally meet with every patient personally. And really this allowed us to optimize our protocols over many iterations, improving at a strong rate, to the point now where we are scanning thousands and thousands of people every single month. With that, we have the largest data set in the world of whole body imaging on proactive screening. We've seen the most patients, and we collect the most data points per patient. And really part of the focus on this growth is working with providers such as yourselves, really to help drive a change in a proactive manner. Patients want this change, right? In fact, many of our patients come in on their own accord and they don't have a family doctor, really, which is why it's so important for us to build this network with you all so we can really help shift that paradigm from reactive to proactive. Here's a look at our facility in New York. I could have put any image up. All of our facilities have the same look and feel. And really it's one of our key strengths is the fact that we own our facilities. In fact, we are completely vertically integrated. We own our clinics, we own our magnets. We only conduct whole body imaging in these facilities. Our clinical staff are Prenuvo employees. Our team of radiologists either exclusively read for us or it's like the primary reading they do. They're all trained extensively in reading whole body imaging. I say this is a big advantage because it allows us to optimize every step of that patient journey. As you can see, we put a really big emphasis on creating a warm, welcoming environment because we know with most patients, they can associate MRI with anxiety. In our world, we really want to make the idea of disease a whole lot less scary by catching it early. And we believe the look and feel of our clinics really help us in doing that. Here's a look in one of our magnet rooms. So the magnets are really built to give a very comfortable and relaxing feel. The tables have memory foam mattresses. Your patients can watch Netflix, TV, Spotify, podcasts, or listen to some health tunes during their scan. We'll scan the entire body, head to toe, in less than an hour. And a lot of people actually come out of the machine feeling relaxed, which is I'm sure you've all had MRIs. That's not normally the case. And so we don't see a lot of claustrophobia because of this. So again, really tailoring towards a top of the line experience, one that people typically would not associate with going to a medical facility. Shifting to today's topic, we want to recognize that October is Breast Cancer Awareness Month. So really we've positioned our topic around breast masses and whole body imaging screening. So with that, that's enough from me. I'd love to throw it over to Dr. Modi.
Thanks so much, Eric. And thanks again, everyone joining us today. We are going to be doing a deep dive into palpable breast masses and screening versus diagnostic techniques. We are really thrilled to have Dr. Ben Johnson joining us today, who is uniquely positioned to speak on this topic with us. He has exquisite training in breast screenings, both through whole body MRI as well as through mammography, his training. So he's going to give us a really unique perspective on the benefits, the cons, the pitfalls of what we're doing with these modalities. So we're going to start again with just a brief introduction to breast masses in general, how we define them as nodules or growths of tissue that represent sort of a coherent material within the breast tissue. These can be benign, which would be solid or cystic, or they could be malignant. So we're going to, of course, delve into both of these things. A really important piece of what we're going to cover today is the importance of history, that a breast mass and a risk assessment really have to go hand in hand in terms of helping us determine what our next accurate steps are going to be. So when you have a palpable breast mass, it's really important for us as clinicians to gather a good history, to perform a detailed physical examination, and then of course to choose the right radiographic imaging for that patient and for that mass. There are non-palpable breast masses, which could be benign or malignant, and those can be felt during an exam at some point. But those are usually detected solely through imaging, through screening techniques. So we're going to kind of talk about both of those. A really important thing to think about is that a misdiagnosis of breast cancer is one of the most frequent causes of malpractice claims in the U.S. And it has unfortunately made us incredibly sensitive, to the point of maybe overly sensitive, in determining the next steps for breast workup. So we're going to talk about how we can get more accurate, more precise with our sensitivity, with our specificity in determining the next steps. Just a quick note, approximately 20 to 30% of patients with non-palpable breast masses will develop a breast cancer. So that's a fairly sizable proportion there. So this next slide is just a breakdown of different breast masses, Eric. We're going to look at both benign and malignant types. The benign you can break into 4 subcategories of non-proliferative, which have no associated risk of breast cancer, and that's going to be your simple cysts, fibrocystic changes, galactoceles. These are things that we see a majority of the time. And then we have proliferative lesions without atypia. Those do have a slightly increased risk of developing cancer at 1.5 to 2x. And those are your conditions like ductal hyperplasia, intraductal papilloma, scars, fibroadenomas, simple or complex, and then plain adenomas. And then we have this miscellaneous category, which gives us a lower risk of developing breast cancer, but they're still important for us to identify. Really common, patients will identify a lesion that ends up being lipoma or abscess or even fat necrosis from trauma. And so it's important for us to recognize as clinicians what is low risk, what is high risk, and these all fall into the low risk category. And then you've got your proliferative lesions with atypia, and these are considered high risk of developing cancer. And those are your atypical ductal hyperplasias, lobular hyperplasias, and then the LCIS category. And then you've got your already malignant tumor, malignant masses, and that comes down to infiltrating ductal breast carcinoma, which ends up being 70 to 80% of the invasive breast cancers in general. And then you've got infiltrating lobular carcinoma, DCIS, and then there's rare lesions like lymphoma, sarcoma, and metastasis from other cancers. I want to just chat a bit about the prevalence and incidence of these conditions. You know, over 25% of women at some point in their lives are going to develop a breast mass. That sort of is, unfortunately, a fact of being a patient with breast tissue. A third to half of all those biopsies result in a negative result. And that is a tremendously low number needed to harm, and again puts the impetus on healthcare providers and researchers to continue improving these processes that we take to investigate suspicious lesions. I'd like to emphasize that a huge majority of solid masses, especially in women under 19, are benign fibroadenomas, and that increasing our clinical awareness of that likelihood, surveillance techniques can really help lower the number of unnecessary biopsies and anxiety that come along with this condition, especially in our younger patients. Despite the low risk of in early adulthood, the fact remains that 1 in 3 cancers in women are breast cancer. And along with routine skin screening, as skin cancer remains number 1 cause of disease in women of malignancy, routine breast screening, though through validated methods, is one of the most important ways we can protect our at-risk population. Thankfully, due to diligent screening programs, public education, and provider support, the 5-year survival rates for women have diagnosed at stage 1 are nearly 100%. Which is truly a remarkable feat. The catastrophic flip side there is the statistic that if disease is not thoroughly addressed until stage 4, survival rates plummet to only 25% at 5 years. So again, the impetus is on us to catch these diseases early and to intervene quickly. So let's start with the key aspects of taking a history to assess risk of palpable breast mass. Breast masses are often incidental by the patient on routine examination, self or otherwise. But the clinical history needs to include your medical and surgical history, the medications and allergies, assessment of risk factors like family history, and now genetic testing, which has now become a major player in assessing risk factors. Information about how and when the mass was noted, and then the changes of that mass over time, and then, of course, any history of trauma. Now, a breast mass is often discovered due to symptoms, and those symptoms that you need to be perceiving are going to be pain, especially related to menstrual cycles, location, duration, nipple discharge, a history of trauma, the location, and then changes in size or symmetry, and then, of course, their skin changes and nipple inversion. Now, the detailed family and personal history can help risk stratify or de-escalate risk assessments based off of these criteria. Genetic testing for BRCA1 and BRCA2 are also a high potential there. Although there is no standardization or consensus about the exact percentages of lifetime risk categorization, average risk is considered to be less than 15%, moderate is about 15 to 20%, and then the high risk is considered at 20% of lifetime. So having a detailed family and personal history can really help us de-escalate these folks or risk stratify them correctly. I like to save this slide. I refer to it often when I'm consulting with a patient, discussing if they really need to be pursuing early testing or aggressive surveillance of a known lump. And so this is a chart I like to remind patient providers to refer back to, because it really does a nice job of helping to identify what the high risk and low risk factors look like. Now, luckily, we have risk cancer prediction models to help us with this history assessment. Now, clinically guiding patients to begin screening for disease depends on multiple risk factors to assess if a patient is at average, moderate, or high risk. The presence of a palpable mass is regarded separately, by the way. So the first thing that we like to use is the Gale model, which is indicated there on the left side of your screen. This is the BCRAT method, where a BRCA status may be unknown. So these are calculators easily accessible both to the patient and to the provider. MD Calc has a reference here on how to use the Gale model. But this is really the premier method that we, at least at Prenuvo, are using when we help confer risk assessments after seeing a lesion in the breast. The other risk calculator I've included here is the BOD-ICA Bodecia, I call it, which is otherwise known as CanRisk. This requires provider login. So this requires a registration by a provider or a genetic counselor. And once you've registered, you can access this risk calculator. And this one takes BRCA status into account when giving a risk calculation, which again will end up being average, medium, or high risk. Now this next slide is incredibly busy, and I don't really want to go through each detail, but this is again just a reference point to explain the differences in the different calculator models. The concept is just to consider the wide range of factors that go into determining a risk of developing malignant breast disease. At the end of the day, the key is to consistently use the same risk calculator for longitudinal assessment of your patients so that you can identify early trends and consistently assess your patients the most precisely way available to you. So again, if I did my original assessment of a patient using Gale, I need to refer back to Gale on their reassessment in a couple of years and then adjust those risk factors accordingly. So I use these calculators as a method of counseling my patients who have breast disease anxiety. I show them the numerous factors that they can manage, such as BMI and alcohol consumption, and then the optional screening for genetic risks. And then I use this to confer some degree of agency back to the patient, who may otherwise feel confined to sort of a fate, or I'm predisposed and I have this sort of this casualty associated with my predispositions. These can help reassess a patient and reassure them, but it can also help you correctly identify patients at higher risk. The next key piece of our assessment for breast lesions is, of course, the physical exam. Now, here's a quick review of that, which is that we need to be consistent and methodical with our approach to the breast exam. It should be noted that current guidelines do not endorse the use of the clinical breast exam or even routine self-examinations for average risk women. So average risk women do not necessarily need to self-examine or get clinical breast examinations. That's a reality that can spare many patients the discomfort of unnecessary testing and overdiagnosis. But once a patient notes a palpable mass or is identified as moderate or high risk, now we need to employ our clinical breast exam and recommend self-breast examinations as routine strategies. Now, note that the variability in breast mass qualities, obvious or subtle, whether it's soft, firm, or hard, mobile or fixed, Breast masses can have a number of different qualities to them. So again, it's important for us to sort of understand what are high risk and what are low risk, which we're going to do on this next slide. But again, I just wanted to include this one here as a reminder to be consistent with your method, to make sure that you have a kind of a baseline to compare your re-examinations with, whether that's from your own or from patients' medical histories. And then, the key factors to inspect are going to be for asymmetry, for skin changes like dimpling or retraction, edema or ulceration, eczematous appearance, and then of course identify the nipple if they have any inversion or retraction there or any discharge. So again, these common features of breast masses, this is another cheat sheet. I keep this one in my files to refer back to when I am assessing a breast mass, because again, this very quickly kind of examines what the different qualities are of different types of masses, and then I can go back to my original cheat sheet, and then that'll help me risk stratify. So this is something I recommend most clinicians have access to, whether it's through their up-to-date subscriptions or through these slides. But just sort of knowing what the different features are of different masses, and then we can say, well, that's a benign thing, and we don't need to be so aggressive about pursuing follow-up, or that has some troubling features, and we need to be very aggressive about these. So the next step I'm going to do is kind of present a case study from the Prenuvo perspective. So this is a patient that we encountered at Prenuvo last year. Patient RK. She was a 61-year-old OBGYN, Northern European descent, and she presented for a proactive screening whole body MRI. She does get her routine screening mammograms that she started at the age of 40 with occasional diagnostic mammograms and ultrasounds depending on the density of her tissue. They've all been negative per her history up to this point, and she denies any palpable breast symptoms at the time of her MRI. Key parts of her history are that she does have some mild asthma, some dense breast tissue, herniated cervical disc, hypothyroidism on thyroid medicine, but also postmenopausal on HRT. Luckily, she was on the patch. Basal cell carcinoma in her right upper back, so we've got some concern for skin, but we now know that she is routinely checking skin. And then she has completed her mammogram and ultrasound, as I mentioned before, just within the year prior to testing with us. So she's up to date. And then the only significant family history is prostate cancer with her father. Vitals indicate a healthy BMI. Her social history is of one alcoholic beverage every 2 weeks. So two times per week. So again, pretty minimal alcohol, but not a smoker. She has a regular exercise routine and a really healthy intermittent fasting diet. And her only real symptoms at this stage were the hot flashes for which she's using the HRT. So essentially, the thing I want to identify here on this slide is that, at least at Prenuvo, we are not getting a full history, that we rely on our provider partners to help us do that. So access to previous imaging reports is missing for us. Access to their lab results is missing for us. Essentially, if not directly reported by the patient, we are operating almost entirely blindly when it comes to accurately assessing a breast mass when we are missing these key parts of the history. And so that's one of the first take-home points for today's lesson, is at least when you're using an outside imaging center to please provide as much history as possible with regard to assessing a breast mass. So what are some of the things missing on this slide? Where are her G's and P's? I don't know how often she's been pregnant or when she had her first and last pregnancy. Her age of menarche, when did she begin having menstrual cycles, at what age? Those are two key parts of a Gale score. When we did do a modified Gale score for her with those pieces missing, we gave her a 5-year risk of 1%, a lifetime risk of 4.7%, very low. Just for the sake of the argument, if we were to add some further details, if we knew that she had her first pregnancy over the age of 30, if we knew that she didn't start menstruation until age of 11, those numbers actually double. Her 5-year risk becomes 2.2%, and her lifetime risk becomes 10.6%. So that's how important those history details are. And so back to this patient, in reality, we're considering her average risk. So screening guidelines, we've got a slew of different recommendations here from different societies. The American Cancer Society, the USPSTF, ACOG, AMA, and the ACR. There is a few variations here when you look at these recommendations. The standard screening for low-risk patients should start with a screening mammogram plus or minus an ultrasound for dense breast tissue beginning around the age of 40, and then should continue at least to the age of 75. The cadence is typically annually, with some data to promote every other year for women at low risk, and then follow-up imaging with diagnostic mammogram and ultrasound for any atypical results. So that is a take-home slide. If you hit next on that again, Eric, you'll see here, again, the USPSTF is talking about starting at the age of 40 through the age of 74. That's a grade B recommendation. And then women age 75 or older, we see that those change just a little bit. And of course, that sort of the USPSTF says there's insufficient evidence to continue. Now, we know women are living longer. And so there's a challenge there to ending mammograms and screening at 75. Should we be continuing longer? There are studies going into that right now. And then, of course, women with dense breast tissue, they conclude that current evidence is insufficient to assess the balance and benefits and harms of supplemental screening for breast cancer for women with dense breast tissue. So we sort of land on, again, the take-home idea that women age 40 to 75 should be getting screened routinely. Mammogram and ultrasound are the standard recommendations. And really a discussion with your clinical provider is the most helpful thing here, that it's so much information out there that our patients are probably getting overwhelmed. Do this, do that, don't do this, don't do that. But at the end of the day, we want to do the best thing for our patient, and that takes their input. So now we're going to talk about those different screening modalities. The first one we're going to chat about is mammography. So mammography is dedicated x-rays of the breast and surrounding tissue, and we have two views to review there, the craniocaudal view and the mediolateral oblique view. So this is just a quick image of what those look like. Mammography is still regarded as the gold standard for breast disease screening. There's a bit of confusion about the inherent risks of a mammogram, so I wanted to demonstrate the relative radiation exposure from a 2D mammogram, if you'll hit next, compared to the new standard 3D in many places. So what you can see here is on the left side of your screen what a 2D mammogram looks like. And now this new 3D technology, which gives us different views and is able to coalesce these different views, really shows you the different value of getting a 3D mammogram. So the 3D is now becoming sort of the standard of care across the board. If you have access to 3D, it's by far the best option. Insurance is now covering that as the primary solution. But in absence of 3D, please still get your 2D mammograms because they can still show us quite a bit and help it get to the right point. We've got here just a quick review of the actual radiation that comes from this. So again, a little confusion about the risks of the radiation. I wanted to talk here just a little about what that looks like. So a 2D mammogram gives you somewhere around 0.4 millisieverts of radiation. So that's our baseline. Now we compare that to a 3D and we increase that by 0.1. So now we're at 0.5 millisieverts for a 3D mammogram. So there's a lot of talk about, well, why would I do a radiation exposure examination when the whole point here is to prevent me from getting cancer? Let's put this in context. The average annual background radiation in the US is all the way up at about 3 to 4 millisieverts per year. So that's what we're working with, is an order of magnitude at almost a 10x, that you're getting that much radiation just from living in America. So when we think about the relative exposure of a mammogram, it's really, really significantly low, and we still want to encourage our patients to think about that. The next comparison is to living in Colorado, which actually bumps you up a whole millisievert to about 4 on average. So I don't think I'm winning over any folks from Denver's tourism board on this slide, but to those who are scared to get a mammogram because of the potential radiation exposure, my response would be move out of Colorado first and then we can talk. Okay. So continuing on with mammograms, mammography is available as a screen film mammogram, digital mammography, and then there's digital breast tomosynthesis, which is 3D mammography. Prior to the mammogram, it's helpful for patients to know that the compression of the breast is transient, that they'll be undergoing some compression, but it's important to reduce motion artifact, which is why we have to do it. And it also improves image quality and reduces the amount of radiation required by doing that. So despite the discomfort, it's still the proven best methodology. Individuals should also provide access to their prior mammograms for comparison when getting a mammogram at a new imaging facility, because that's going to give us a really detailed idea of if we're looking at change over time or if we're looking at a de novo lesion. Mammogram is best studied and is the only imaging technique that's been shown to decrease breast cancer mortality. The false negative rates for 2D mammogram are up to 20%, so that's a hit on 2D. But digital mammography versus screen film results in similar detection, fewer false positives. So that's why digital mammography has become our go-to, and now, of course, the rise of 3D mammography. So an even lower recall rate and statistically higher cancer detection rate thanks to that technique. So radiation exposure, again, we talked about that on the last slide, really nominal when you're thinking about the grand scheme of exposure risks. And really quick, I wanted Dr. Johnson to maybe chime in on that last slide. Dr. Johnson, if you're there, Can you talk a little bit about what you're looking for when you use a mammogram? What makes it the gold standard for screening?
Sure. So, essentially there's a lot of subtlety to mammography and mammography interpretation, but when you take a forest look from high above, basically I'm looking for four different things. And there's four words that we use in the BI-RADS lexicon, and anyone who's read a mammography report, that's a BI-RADS 0 or a BI-RADS 4 would have, in general, if it was done correctly, heard one of these four words. So I'm looking for a mass, which is basically exactly what it sounds like. The mass could be a high density mass, a low density mass, an isodense mass. It could have spiculation, it could be round, it could be partially obscured, and all of those words are kind of secondary descriptors of the big category of mass. Could be looking for calcifications. So, as you get older, almost all women have calcifications, but you basically end up looking for a very specific pattern of calcification, which can be a sign that something is going wrong. And Dr. Modi, you spoke earlier about some of the earlier proliferative processes that can lead to malignancy in the long term. And I like to think of all of these breast cancer diseases that they kind of exist on a spectrum. Things start to go wrong and then they get a little more wrong and eventually they become invasive disease. With calcifications, oftentimes when we see developing calcifications in a very specific pattern, that can show us that maybe there's some atypia going on, or it could be becoming in situ disease. A lot of times early calcifications, that's what we're looking for, would be DCIS. So we have mass, we have calcifications. The third broad category that I look for is asymmetries. And so that's basically, we're looking at both breasts and I'm looking for a difference kind of from one side to the other. Again, within that broad category of asymmetry, there are subcategories. So you could have a focal asymmetry, which means you see that difference from the other side in both the craniocaudate and MLO projections. You can have a one-view asymmetry, which you really only see on one of the two views. A global asymmetry, which you kind of see in where you have one entire breast is more dense or different looking than the other. And then finally, the one that I find to be the most worrisome and helpful is the developing asymmetry. And this is something that I'm going to talk about later, and I know Dr. Modi's already touched upon, but really having prior comparisons is absolutely critical for screening in breast cancer. If you look at two normal brain MRIs, the brains look very similar. So it's, when something goes wrong in a brain, from a normal brain, it can be quite easy to see with imaging. With breasts, no two breasts and breast tissue pattern is the same. So a lot of times what we rely on is a change from the prior year to really find the difference. So developing asymmetry is something that I really look out for, and comparing from old exams. And then the final thing is architectural distortion. And that is where the tissue is being pulled to one point. So some cancers, particularly ductal carcinomas on the lower grade side, tend to slowly retract tissue in, and it gives kind of a stellate pattern on the mammogram. Tomosynthesis is absolutely critical for looking for architectural distortion. The older 2D models, which are better than nothing and certainly can pick up architectural distortion, are just not nearly as sensitive as tomosynthesis. The architectural distortion tends to be a finding we see often with developing lobular carcinoma. So a different subtype of cancer in the breast, but one that's very important and can be caught well with the tomosynthesis imaging. So those are my four categories: mass, calcification, asymmetry, and architectural distortion.
Outstanding. Thanks for walking through that with us. The next modality that we're going to chat about is breast ultrasound. So breast ultrasound, screening ultrasound is currently not recommended for average risk women. However, ultrasound has increasingly been mandated in the US as an adjunct to mammography for women with dense breast tissue. So as of right now, if you have these kind of risks assessed, if you have documentation of dense breast tissue, you may automatically qualify for an ultrasound with your mammogram. Unfortunately, in a large majority of women, it's not documented very well, and so they'll get their mammogram, or if they go to a different location, they'll get their mammogram, and then they have to get called back to get that diagnostic mammogram and that diagnostic ultrasound done. So once again, it's important to really include that history and prior imaging if available. Ultrasound routinely used for diagnostic follow-up of abnormalities detected on screening mammogram. So again, we use that as our next go-to step. Ultrasound is still not routinely recommended for women at moderate risk, so this is controversial, at that 15 to 20% lifetime risk calculation, and this is including most women with a family history of breast cancer, but without known genetic syndrome. So this is that kind of a gap where we need to start to close in on our patients and really identify family history, but also if there's genetics available, we need to know that. And then the last point I want to make here is that our screening test carries a substantial risk for false positive results. So this is one of the reasons why ultrasound is not routinely recommended for the initial test and for routine testing in patients at average risk because of the false positives. We're going to get 52 instead of 22 false positive biopsies out of 1,000 patients. So these studies are indicating equivocal outcomes by adding same-day ultrasound to screening mammogram. That's why we kind of use it as an adjunctive or an add-on test in some cases. So again, back to Dr. Johnson. Dr. Johnson, how does ultrasound work to image this breast tissue? When we're looking at these pictures on the screen and we see the architecture on the left, we see a mammogram in the middle, and then we see ultrasound. It looks very different. What's going on there?
So, with ultrasound, basically you're using sound waves to detect interfaces between tissues. So sound travels at a specific speed in different mediums, different types of tissue. When those sound waves hit an interface, for example, if it went between water and oil, the speed will change. And some of those sound waves will also reflect back. So basically your transducer is getting signal from reflected sound waves that are passing through different interfaces. So breast fat, for example, has a very different density than fibroglandular tissue. So when sound waves pass through and reflect back, it's producing a signal that can kind of demonstrate the contrast between those interfaces and give you an image. Just like any different modality, there are pluses and minuses and Dr. Modi, you went over some of these. I would say ultrasound is incredibly user dependent and it's very difficult to reproduce. No two mammograms are going to be the same. However, they're going to be relatively similar because we're positioning the patients in a very uniform way. With ultrasound, just small differences in the angle of the transducer or the position of the breast, lying on the patient is going to give a very different image. So it's always going to be highly user dependent. I kind of look at it as best when, we're troubleshooting something and the radiologist is there scanning in real time. You have that temporal resolution. You can really kind of drill down and look at something very specifically. But for me, again, I talked about developing asymmetries with mammography and being able to compare to prior. That's really a major limitation with ultrasound, even with screening whole breast ultrasound, is that the ability to compare one exam to the next, really, a lot of that gets lost between one exam and the next exam. I think ultrasound is also great for procedures. Again, it's real time. You can really get accurate positioning with a biopsy device or a needle. Again, in some women, adding whole breast screening ultrasound can be beneficial. It might help you catch more things that maybe could be missed on mammograms. That does come with the cost of potential false positives and increased callbacks. But, all of these things are, you kind of look at, the radiologist quiver. These are all like tools in our Swiss Army knife that we have for certain and specific situations. I always go back to that mammogram as the gold standard screening tool. And then we draw on things like MRI or ultrasound for more kind of nuanced or finessed workups.
Yeah, the kind of confirmation, the adjunctive treatments, right? Excellent. Thank you, Dr. Johnson. So moving on down now, we're going to talk about diagnostic breast MRI. So diagnostic breast MRI, let's get some of the big ones out of the way. Screening MRI is not recommended for average cancer risk patients. Based on guidelines from the American Cancer Society, that data is considered insufficient, so grade I for women at moderate risk. MRI is only routinely recommended in combination with mammography to screen for high-risk patients with a greater than 20% lifetime risk, so that goes to your risk calculators. Its primary function is to rule out cancer when other problems in the breast develop, such as a possible leak or tear of a breast implant, very dense breast tissue following mammography, or history of radiation treatments to the chest area. So now, similar to ultrasound, a dedicated MRI is under consideration as adjuvant to mammography in women at moderate risk, only after discussion regarding those patient preferences. So what we think about here is that, with a diagnostic breast MRI, what's happening is a signal comes from proton relaxation, if I'm understanding that right, no radiation, and it uses a dedicated breast coil, so there is still some compression of the chest. The lower resolution than mammography, MRI has lower resolution than mammography, as the voxel size for these Prenuvo scans, for instance, is at 0.75 by 0.75.5 millimeters. So now the question comes back to Dr. Johnson. Okay, so Dr. Johnson, how is the sensitivity and specificity for diagnostic MRI?
So for a diagnostic breast MRI, the sensitivity and specificity is quite excellent. I don't have the numbers in front of me, but it is quite good. I would say the specificity is not as great as we would like it to be. And that's why, as you were getting at earlier, even adjunct breast MRI, where there was some talk, you know, in the early stages that this is something that people who have dense breast tissue needed. It turns out we really reserve the diagnostic screening, the screening breast MRI, dedicated breast MRI, for patients who are at high risk. And that's because the specificity is not as great. So we see a lot with breast MRI, it's not all cancer. So, when we expose patients to that potential harm of overdiagnosis, meaning false positives, biopsies that come back as negative, we want to make sure that it's a patient who has a high pretest probability, if that makes sense. The contrast component of it is very important. Going back to mammography, I'm looking for masses, I'm looking for calcifications, I'm looking for asymmetries, I'm looking for architectural distortion. A lot of those things on the diagnostic breast MRI are kind of best evaluated with post-contrast imaging. So calcifications, or DCIS, on breast MRI is seen as non-mass enhancement. So oftentimes that's totally invisible on the non-contrast portion of the exam. Masses, one of the key things on masses on breast MRI is looking at the contrast kinetic curve. How does it enhance? Does it enhance fast and then wash out? Does it slowly enhance and then stay that way? So again, even for masses, contrast becomes important. Architectural distortion, generally best seen on the post-contrast sequences. So yes, very, very good test, not quite as specific as we'd like it to be. So it's going to have higher false positives and potentially biopsies that don't yield malignancy than other tests, and that's why we generally reserve that particular type of test for women who have a high pretest probability or a lifetime risk of greater than 20%.
I wanted to show what a true breast MRI looks like, because I think, again, coming from Prenuvo and how we do things our way with the whole body technique, is important to see what the differences look like. So now this is what a diagnostic breast MRI is going to look like. Your patient lays face down on a padded scanning table. There's actually a hollow space on the table for the breast to fit in. And then that hollow space has a coil that gets signal from the MRI, from the magnet, and then that table is going to slide into the large opening to allow for the imaging to occur. Now, the next click there, this is what those images look like. So, this is a breast MRI from screening of a BRCA carrier, so someone who's been determined at high risk with lesions. So, we want to, again, understand that the diagnostic MRI is useful for screening women with genetic mutations that confers very high risk for cancer. It's that kind of that true positive, that specificity versus sensitivity. And then MRI-guided core biopsies come next, and that's confirming an invasive ductal carcinoma in this patient. So once we get the diagnostic MRI, then we start to implement these interventions like biopsy. So it really is a very, very important method to understand why it's not routinely used for average risk, that there are some discomforts with the positioning on the table and the coils and the IV contrast. But again, for patients with significant risks or known lesions, that's why we go to it. So this next slide is the ACS's recommendation for breast MRI as an adjunctive to mammography. Right now, they're recommending an annual MRI screening based off of high risk of breast cancer and high sensitivity of the MRI for people with a BRCA mutation, first degree relative of a BRCA carrier, but maybe untested, and then that lifetime risk greater than 20 to 25%, defined by one of those risk calculators that we mentioned earlier. Now, recommendation for annual MRI screening based on high risk of breast cancer is for patients who have radiation to chest between 10 to 30 years. So those are patients who are getting routine, maybe thyroid scanning or chest lung scanning, Li-Fraumeni syndrome and first degree relatives thereafter. And then patients with these other conditions, these other syndromes with first degree relatives as well. Now, the insufficient evidence to recommend or against MRI screening comes from a lifetime risk of 15 to 20% on one of those risk calculators, maybe lobular carcinoma in situ or atypical lobular hyperplasia, maybe atypical ductal hyperplasia, heterogeneously or extremely dense breast tissue, there's insufficient evidence, and then women with a personal history of breast cancer, including ductal carcinoma in situ. Now that's interesting, insufficient evidence to recommend for or against. So this is sort of a judgment call. that if your provider and the patient work together and determine that MRI is the best solution, you will proceed. But after discussing these risk factors, you may elect against it and instead do ultrasound or mammogram. And then the recommendation against MRI screening, a pure recommendations were for women who are at less than 15% lifetime risk by calculation. So that's, again, something I would afford to my patient is show them those risk calculations, show them the numbers that correlate with that, and hopefully that can reassure them that maybe an MRI isn't in their best interest. I wanted to here mention just a few things about BI-RADS. So once your patient has completed dedicated breast imaging, being familiar with the BI-RAD system is really important for that clinician. And thankfully, every dedicated radiology report now includes these reminders as to what follow-up cadence and risk modification should look like based off of their BI-RAD score. So BI-RADS is, of course, the breast imaging reporting data system. It was developed by the ACR, the American College of Radiology, to standardize the format of a radiology or a mammogram report. But now we're using BI-RADS in the world of ultrasound and MRI interpretation so that that scoring system remains kind of constant and we can continue to understand those risks. So the following elements include sort of the indication, the breast composition, and if it's fatty or scattered dense tissue, heterogeneously dense or extremely dense. Any abnormalities or important findings are included, and then of course comparisons to previous examinations. So again, not incredibly critical that all clinicians keep their BI-RAD scorecard in their pocket, because luckily a lot of reporting now includes what that BI-RAD score is, and thankfully our radiologists are keeping track of that for us. But I did want to include it here just so we sort of, again, had a reference point for understanding what different BI-RADs look like. So we have a BI-RADS of 0, which is a sort of an incomplete study and need additional views. We have a BI-RADS 1, which is purely negative, so continue routine screening. That's a 0% risk. And then we have a BI-RADS 2, still considered benign. So that could be like your fibrocystic lesions or your fibroadenomas, in which case we would continue routine screening, and essentially still the risk score is considered 0. And then you've got your 3, 4, 5, and 6 categories, which increase the kind of risk associated with the lesion, which will lead to biopsies should be considered, required, or confirmed. And then at that point at level 6, you've got proven malignancy. Everything in between is sort of increasing risk associations. Following your screening imaging, and now you've got diagnostic imaging, I wanted to just show what dedicated diagnostic mammogram imaging would look like after a positive screening test. So again, we talked earlier about spot compression. These are tailored views that the radiologist will specify. These are adjunctive views to digital breast tomosynthesis and ultrasound if needed. And then you've got your focal spot compression views with magnification. So, the routine CC view on panel A there shows calcification in the lateral aspect of the breast, and then the size, shape, and distribution of these calcifications are better seen on that magnification view in panel B down below. We have a different pleomorphic appearance, we have segmental distribution of these numerous calcifications in that image, and those are oriented toward the nipple, so this is actually an image of ductal carcinoma in situ. The next phase of the presentation is going to talk about some potentials for whole body MRI and breast screening, or some potential imaging, and whole body MRI is one of those potentials. So it's important to note that each of these benefits to whole body MRI are not for a screening population, but rather for a known disease population. So at this point, Prenuvo is not endorsing whole body MRI program for surveillance, follow-up, or dedicated breast imaging detection as a standalone option. Our position is that it will function well as an adjunctive test to traditional modalities, which we've been talking about. The benefits of whole body MRI are that we identify hypercellular lesions, assess initial staging and subsequent response, and then a whole body MRI can evaluate post-therapeutic changes. None of those things is actually within the screening protocol at Prenuvo. So if you have known breast cancer, known breast disease, we're going to refer you out to diagnostic imaging rather than doing our whole body protocol. The future of whole body MRI as a potential option for breast disease is sort of tenuous at best right now. On the pro side, we have that the protocol is feasible, reproducible, performed in a relatively short time, but the quality of images and the quality of images are obtained within 40 to 45 minutes without IV contrast. So those are all the pro side of this argument. But some radiologists, and not at Prenuvo, will actually need to use gadolinium contrast if liver and brain screenings are also planned. So again, if you're really trying to stage, contrast material is going to be required, which again, Prenuvo and other whole body screening clinics don't employ. So again, this is just a quick review on the right side there of all the different sequences required to get like a thorough whole body MRI view of the breast. So Dr. Johnson, chime in again if you don't mind. What do you see as the strengths and weaknesses of whole body protocol with regard to breast screening? Why isn't it considered an option for standard of care?
Well, again, I think there's a couple major limitations. One, we're scanning in order to get the whole body in less than an hour. You're scanning with very specific coils that are not going to get as much signal to noise ratio and resolution in the breast. So you touched on the voxel size on the primary workhorse sequences we use. It's just not a high enough resolution to catch the smaller cancers that we're trying to catch to get make a major difference at early detection. So resolution is one problem. Another big issue is that as you said, we're not giving contrast. So a lot of times, especially in women with dense breasts, developing malignancies will have a very similar signal pattern on the sequences we use for whole body MRI to the background fibroglandular tissue. So if a woman has dense breast, those findings can hide very, very easily within the breast tissue. And that's where contrast becomes really important. The diffusion protocols, which can be actually quite helpful in other parts of the body, end up being a little bit more nonspecific. I think when we see something morphologically on a scan, like if I see some architectural distortion and I see some restricted diffusion, that definitely makes me a little more worried. But seeing restricted diffusion on its own, not necessarily going to be enough to be a slam dunk. And if we decided to look at every diffusion lesion, as I'll show you with some cases later on, we'd be sending every woman back for diagnostic mammography and driving everyone insane. So really, I just think a lot of it is just we haven't really found that holy grail sequence yet, especially at the resolution that we're doing. I mean, even with a dedicated breast coil where you're getting much higher resolution imaging and higher signal to noise ratio of the breast, non-contrast imaging is still not a tool that would be recommended for screening at this time. And it's a shame because I know there are women out there who are not comfortable with the radiation or the technique of mammography, but really, the way I look at it is screening is a choice, and if you're going to screen for breast cancer, mammography is the way to do it in 2024. And we'll continue to monitor it and work to see if we can get things better. And again, that is not to say we don't carefully examine the breast with the whole body protocols. We do. It's just a little bit limited. So as an adjunct, yes, it's another set of eyes with a different technique to look for something. It's just not going to be as sensitive or specific as mammography, dedicated diagnostic breast MRI. So kind of think of it, like a PET scan, for example. You're getting the whole body, but by getting the whole body, that comes at a cost.
Thanks for that. So this next slide just shows us again a quick review of what the whole body technique is going to look like versus the diagnostic MRI. Again, I wanted to keep hammering this because we counsel a number of patients who may be under the idea that the MRI that Prenuvo or these other whole body screening clinics offer is going to kind of thoroughly examine or investigate for breast disease, when in reality the science and the technology just haven't arrived at that point yet. If you have suspicions and if you have high risk factors, a diagnostic MRI through your traditional healthcare providers is absolutely the gold standard. So I'm now going to go back to our case study. Our patient RK, who you'll recall had the bioidentical hormones, had a normal breast mammogram ultrasound, came in for her MRI for us. And then we did, as Dr. Johnson pointed out, we did end up detecting something. So it's capable of detecting some things. In this patient, we found a 1 centimeter focal left breast lesion on her DWI series. So if you can see from these images here, that's what's being identified with that red arrow. It's in the left outer quadrant, 12 to 3 o'clock position relative to the nipple, mid-deep, 1/3 deep depth. And then that's within the background of her dense breast tissue, which they knew about. And so the radiologist identified this as potentially oncologically suspicious, and they gave an OncoRad score of 4, which is sort of a moderately high risk association. So once this report was given to the patient, they were referred back to their primary team for further investigation, and they underwent dedicated breast MRI with contrast protocols, and lo and behold, they confirmed a 5 by 5 by 6 millimeter lesion in the left breast. And that was confirmed as a BI-RADS4, so very similar to the OncoRad score of 4, BI-RADS4. OncoRads, for those who are unfamiliar, is the score system that we use at Prenuvo for whole body MRI risk. So now BI-RADS4 is now specifically for the breast. So Our patient underwent an ultrasound that showed a suspected 1 centimeter fibroadenoma in the location of the originally detected lesion. That's important I point out. So a benign lesion was found in the original location. We actually found this 5 by 5 by 6 lesion in the left breast at a different location. So it was sort of a happy coincidence that we overcalled one lesion, but then detected a second lesion. So now this patient was referred for MRI guided biopsy, and pathology confirmed intraductal papilloma 5 by 6 millimeters without atypia. If you remember my cheat sheet at the beginning, this is a intraductal papilloma, solitary lesion, and that actually has a proliferative without atypia categorization. So there is some increased risk of developing breast cancer, 1.5 to 2x, but is otherwise known as a benign lesion. So happily for this patient, given the low risk of the malignant potential, a clip was placed to mark the lesion. The patient was referred back to routine mammography and ultrasound in 6 months for surveillance. So a fairly happy outcome. The question I'm going to pose here is, did we help or did we harm this patient? Screening MRI, like a whole body MRI at Prenuvo, is like a superpowered physical examination, and we continue to diligently research that superpower and refine our techniques and our claims to make sure that we use the powers for good. So in this case, what did we end up doing? We kind of reminded the patient that prolonged exposure to HRT could contribute to breast pathology. We supported her otherwise excellent lifestyle of intermittent fasting and healthy BMI control, regular exercise, her rare alcohol consumption. But at the end of the day, we didn't really change this patient's mortality, morbidity. And so again, this is why we do require this adjunctive use of mammogram and ultrasound, where we might detect things on the whole body. We need to confirm it with those other techniques. The last couple of slides here, I kind of challenged to put in, but we're going to talk a little bit about thermography. What is it? We're hearing a lot more about it now, and I want to comment on it. So thermography is an emerging technique that uses infrared cameras to detect heat emissions from a targeted body region. So as cancer cells, this is based on cancer cells, as cancer cells multiply, they need more oxygen-rich blood for growth, and that increases the blood flow to a tumor, and that raises the temperature around a tumor. So of course now scientists have developed thermography as a way of detecting that increased blood flow and temperature. The thermography is theoretically not sensitive for non-malignant disease. We're going to come back to that. So thermography from all the available data demonstrates sort of a higher accuracy and cost effectiveness, and that's some of the things that technology touts due to recent developments in thermosensors, imaging protocols, computer-aided software. So AI now emerging in thermal imaging have this potential to detect early stage breast cancer. At least that's what thermography proponents are talking about. But, big but, thermography also has difficulty discerning non-cancerous conditions like viral, bacterial, or fungal mastitis. And herein lies the rub, that as much as a thermography can help detect, potential tumors and cancers, it's also going to overshoot, and it's going to misdirect people with very simple conditions and lead them into getting maybe really dangerous techniques performed to kind of pursue these. So again, I've put this slide here just to help understand what the differences are, the next slide, between mammography and thermography. At the end of the day, thermography has not panned out as a proven long-term method of detecting safely breast diseases. Will it pick up breast diseases just like a whole body MRI? Yes. But should it be used as a solo method? No. So it does have an FDA approval for adjunctive to mammography, only adjunctive, and even then it hasn't made its way into any standard guidelines. So thermography still lives sort of on the fringe here. And technology is emerging and science is being done. We can see here what the thermograph looks like. So on the left is your breast thermal imaging, and then in the middle there you have your blue boundary on the grayscale showing those blood vessels sort of extracted by software. But overall, just look at these numbers. We have a true positive of 71, and then a false positive of 69 with thermographs, and then a true negative of 323, and false negatives of 7. So a significant number of false positives, almost as many as the true positives. Once you become symptomatic, the numbers don't get a ton better. You've got 62% true positives and then 52 on the false positives. And then on the asymptomatic patients, our screening population, we have a really high proportion of false positives. So at this point, nobody is prepared to push thermography as a standard of care. As used an adjunctive to mammography and ultrasound, it can be very effective and helpful, but it should not be used as solo treatment. For those of you who have more time, we can keep going with a couple of cases I asked Dr. Johnson to put together, and if he's available to just chat with us about a few images that he put together from whole body MRI to show us the pros and cons.
All right. So we're going to just kind of quickly go through some cases here. So here's one 53-year-old female came for a Prenuvo whole body scan. She did on her history form report a right breast lump. Here on the left of your screen, you can see the axial T2 screening sequence. You can just note immediately kind of the difference in the resolution and fidelity of the imaging of the breast compared to those diagnostic dedicated breast MRIs we looked at earlier. Despite this, you can see a relatively large oval mass there in the right breast. On the right, you're looking at your diffusion sequence. You can see that this mass has markedly a large amount of restricted diffusion signal, showing that the water molecules within the mass do not freely diffuse compared to the tissue around it. This corresponded to the patient's palpable mass, and we did see it well with the whole body MRI. I would argue that, this was something that she knew she had because she had a palpable lump, so would also have been seen with mammography and ultrasound. It was diagnosed and came back as a lymphoma. A relatively rare presentation of a primary malignancy in the breast, but this was a large B-cell lymphoma. Okay, so here's a more subtle one. The axial T2 images there on the left. So this gives you kind of a really good look at the struggles that we're having here. If you look at the breast fat is white and the fibroglandular tissue is that more gray signal. You can see that when this patient has kind of heterogeneously dense to dense breast tissue, and you can see that it can be very difficult to pick something up when it's contained within the fibroglandular tissue itself because the signal is so similar. On the right, we did have some restricted diffusion there, so that clued us in to that area, particularly since the patient complained of a right breast lump. Called that out. She went for mammography and ultrasound, had a biopsy, and this came back as invasive ductal carcinoma. So here the diffusion really played a role in letting us see this. Again, we were very clued in by the fact that the patient reported on her breast history form that she had a lump on that side. Okay, so more on diffusion. So this is the same patient. So we could see here multiple other areas of restricted diffusion that end up not being cancer. And actually, when you look at women, especially with dense breast tissue, depending on the amount, kind of the composition of that fibroglandular tissue, if there's more ligamentous structures, you're going to get some patchy restricted diffusion. So, looking at those first two cases, you could say, oh, wow, it looks, it must be pretty easy to detect these breast cancers if we see how dark they are in diffusion. Well, it turns out that that's not that specific of a finding, and we can't just go calling everything we see on diffusion, otherwise we'd be calling everyone back. Okay, here's another case. So no symptoms reported on this one at the inferior aspect of the breast. So this is where, again, I think whole body MRI can be better when you're getting a lesion that is forming outside of the fibroglandular tissue. So within the fibroglandular tissue mound, especially in patients who have heterogeneously dense or dense breast tissue, it can be very difficult to differentiate normal tissue from a developing malignancy. In this case, she's developing a lesion with some architectural distortion and some restricted diffusion. You can see the little stellate pattern around that image on the right surrounding the mass, which is that tumor pulling in tissues like I was talking about with architectural distortion on mammography. And this appearance on the whole body MRI is worrisome. So this is a case that was picked up without symptoms, sent for diagnostic mammography, ultrasound, biopsied, came back as estrogen receptor, progesterone receptor, HER2 receptor positive, negative. So estrogen and progesterone positive, HER2 receptor negative, invasive ductal carcinoma. Okay, another one, 37-year-old, no symptoms reported. So you can see that the breasts on the middle image are facing inferiorly. Actually, the two images in the middle and on the right are facing inferiorly, and the other one is rotated a little bit to the left. But you can see, again, the breast tissue versus the breast fat, but you can really struggle to see anything different between the fibroglandular tissue itself. There is some diffusion signal throughout the patient's heterogeneously dense breasts, but nothing that stands out as focal. At the time of her examination, she did not report any symptoms. So this was reported out as negative. I didn't report this case, but I would have reported this out as negative going through it myself. And a few weeks later, she felt a lump in her left breast, went for diagnostic mammography and ultrasound, which showed some architectural distortion on the mammography and shadowing on ultrasound, and biopsy came back as lobular carcinoma. So this is a case where screening whole body MRI just does not get the job done. Okay, so those were some malignancy cases. Another totally non-malignant entity that we can see very well with our screening whole body MRI protocols is for patients who have silicone implants when we look for implant integrity. So these are two different cases. On the left, you can see the difference between the two implants. One that has some kind of linear round signal within. We call that in radiology the Linguini sign, which is basically demonstrating that the implant capsule or the intracapsular rupture has occurred. So you have a capsule of the implant itself, and then your body creates a capsule too. So when we're looking for integrity of implants, we're looking at intracapsular rupture, which is the actual implant capsule, and extracapsular rupture, which is the body's capsule that forms around it. Our examinations are not great for extracapsular rupture. For those, you really require a silicone selective sequence and a dedicated implant integrity MRI. But for evaluating for intracapsular rupture, our study is highly sensitive. I've seen many throughout the Prenuvo scans I've read. You can see it on the left and on the right images, the differences between the two implants. So this is an area where our protocol is actually quite good. Okay, so I'm going to kick it back to Dr. Modi.
Thank you very much, Dr. Johnson. Those are really helpful to see the different values of the Prenuvo scan. So we're going to wrap this up. The thesis of this presentation was really to still review the current up-to-date guidelines and recommendations when it comes to screening for breast disease. And where we land there is that screening mammography is still the only breast diagnostic imaging modality that consistently has been found to decrease breast cancer-related deaths. Its success is thanks to those three distinct features of the different views of the craniocaudal, the mediolateral oblique, and then the breast compression technique. There is radiation exposure. We're not going to lie about that. But then you have to consider that comparison of the radiation that comes from a mammogram annually versus the routine radiation exposure just living in America. It's not always a great thing to add more to more, but at the same time, comparatively, the amount of disease we can detect with mammograms, the benefits far outweigh those risks. So, and then think about those individuals with BRCA1 and 2 mutations. They're at even greater risk for that radiation-induced cancer. So then we can think about, that's why we go over to things like the ultrasound and the MRI, at least without contrast initially. And then you've got digital mammography, which has come along, allowing us to get even improved quality of images. It helps facilitate interpretation. But the mammograms really have now come down to screening versus diagnostic protocols on the next slide. And that diagnostic mammograms are performed to evaluate breast abnormalities, symptoms, clinical findings, follow-up of abnormal findings on mammogram screening, and are distinguished from screening mammograms. Then you've got the idea of quality control when it comes to mammography and other imaging, ultrasound and MRI, that we need to understand our BI-RADS reporting system, and we need to kind of follow the recommendations that have been established around those. Finally, the limited role for ultrasound, MRI, and thermography, that ultrasound is not typically used for routine screening for average breast cancer risks, although whole breast ultrasound screening may detect early disease that are mammographically occult. Patients with dense breast tissue are really going to benefit from this one, and that's why we are now starting to offer it more routinely. Diagnostic MRI, again, still referred, just really kept for our patients at high risk of known disease. But you have to remember, if you're doing diagnostic MRI, you're using dedicated coils, IV contrast, the direct positioning on the bed, upside, you're now flipped over horizontally, and that's what gives diagnostic MRI its ideal ability to detect diseases, but less than ideal for screening. And then last but not least, our whole body MRI and thermography, these kind of emerging technologies coming from a company that does whole body MRI. You know, it's just important for us to know what our limitations are. And so at this point, you know, if you are getting a whole body MRI, just remember that it is an adjuvant to your traditional screening techniques, that is not replacement. If we do detect something, we're going to refer you back to those traditional techniques. So we really want to make sure that patients are fully aware of the risks and the benefits of doing our scan, particularly in regard to breast imaging. Thermography, the jury is still very much out, that there are some benefits to using thermography in terms of the modality, but the side effects of false positives really are troublesome, and so we are not recommending those at all formally at this time. I really appreciate everyone for joining us today. I think that this was such an incredibly important discussion to have, especially coming from our organization, to understanding what technology is doing with breast imaging and how we can really impact long-term survival rates in this country. So again, we implore you, if you have questions or concerns, please reach out to us. Otherwise, I appreciate everyone's time today, and thank you very much.
Thanks, everyone.
Thank you very much.